I'm going to turn, if you want to go back and take your seats, that's fine too. I'm going to turn to public comments, and I'm going to alternate between people in the room and people in cyberspace. So again, just to remind people that please limit your remarks for 2 minutes. That will give us about 7 speakers. And just start by saying who you are and if you have an organization to please. So please, sir.
Thank you. My name is John Gardner. I'm functioning now.
Can we hear this okay? No. So you might want to just lift. Is the mic on?
Oh, let's see.
Okay. Now you might want to just hold it up. You're kind of tall and the mic is short.
Okay. Is this better? Can you hear me clearly now? All right. My name's John Gardner. In my late retired and post-retirement years, I've been focusing primarily on scientific ethics, including medical, but only peripherally. My issue is not with mainstream ethical things in this discussion. I know you're all ethical people. You're all doing ethical things. But I'd like to bring up a couple issues that may apply here, and maybe FDA could take some interest in this. And this relates to the leftover opioids that are sent home with or made available to patients who don't need them. My own experience is that I'm typically sent home with 10. I use about 3. The rest I have learned not to keep in a drawer. For one thing, teenagers and young post-adolescent people can take those drugs out and sell them to their friends at a very nice profit, and that is not good for the community. But when I don't do that, I have no idea what I'm supposed to do. I hear that I shouldn't put them in the garbage. I shouldn't flush them down the toilet. But I only hear negative advice. I wonder if the medical community, as part of this problem, could tell those of us who know we have many more opioids dispensed to us than we're ever going to use, what we should do with them.
Thank you very much. We're now going to take a comment sent to us over the internet. I'm going to ask Roberta Wedge, our study director, to read one.
I'm going to paraphrase this a little. What about, there are patients who have noxious side effects to some opioids, but...
A little closer to the mic, please.
Sorry. Some patients have noxious side effects to some opioids but tolerate other opioids better. If they request an opioid that does not come with noxious, for them, side effects, they are considered to be med-seeking their preferred opioid, and the practitioner refuses to give the particular medication that they request.
Okay, thank you. Any other comments from this room? We have one. Go.
Hi there, I'm Maureen Cooney. I'm here as a representative of the American Society for Pain Management Nursing, but I'm also a pain management nurse practitioner in New York. So a couple of comments I'd just like to make. One is that an issue was brought up before, or a comment was made before, about a trial of non-opioids before initiating opioid therapy. And I would just ask the panel to be very careful in considering that trial. How long is a trial? If you have a patient who is having severe pain, how long do we allow that patient? How long do we wait before we would introduce an opioid, when we know that in many cases an opioid may be effective? The other comment I would like to make that we're very concerned about is patient education and the use of a number to quantify pain and prescribing by a number. We know that our population has become very comfortable with saying my pain is a 4, 5, or 6. But how does that correlate to actually prescribing? We need to move away from the use of a number to describe pain to taking into account many more variables that describe pain for a patient, and then prescribing based on those other variables as well as the intensity of the pain. Thank you.
Thank you. Another comment from the cyberspace.
All right. this is slightly longer. There's substantial variation in pain intensity for a given diagnosis. The variation in pain intensity for a given diagnosis is accounted for largely by mindset and circumstances, such as stress, distress, and effectiveness of coping strategies. Safe and effective alleviation of pain is accomplished with few opioids in most of the world. If we say that we are going to reserve opioids for severe pain or when people are dissatisfied with other approaches, then we may be at risk for misdiagnosing and mistreating mental and social determinants of health. I think this merits very careful consideration and should be top of the mind. Such misdiagnosis and mismanagement for the psychosocial aspects of health and comfort seem to be a key part of the current opioid crisis.
Thank you. Comment from the room here? Judy?
Hi, my name is Judy Staffa. I'm an epidemiologist and I work at FDA with Dr. Throckmorton. And I just wanted to follow up with a couple of comments from the discussion I've heard. There's been a lot of discussion about the detail at which to get to when we talk about indication-specific recommendations in clinical guidelines. And I think that's something that I think the clinicians on the committee are probably in the best position to determine how far down into detail should we go. But I'd like to just inform you that some of what drove that is a reaction to some of the one-size-fits-all strategies that we've seen out there. And in the research that we've done and that a lot of the research that's been published, it's very clear of the variation. It depends so much on what a patient is going through. We thought we could do better by actually trying to look at what's happening to the patient rather than just global, everyone gets 3 days, everyone gets 10 pills, whatever that is. So if you can bear that in mind as you're thinking about that, it may help you think more about what was intended when we wrote this. Secondly, it's very, very important to us to be thinking about where the evidence lies. I think some of how we've gotten to where we are was not really knowing what the evidence shows, but going by our gut. And that maybe we're at a point where we really need to be looking at the evidence because we may be surprised by what we find when we see that. And then just as a comment to address the gentleman's comment earlier, FDA actually has something on our website called a flush list. I didn't know it was there, but it is, and it's actually one of the most viewed sites on our website that actually gives some guidance about which medications are safe to flush. And there are many opioids on that list. We're also in the process of updating our labels to get more information about that. So thanks.
Thank you. Another comment from Ether.
My name is Jurcan Gardner, and I'm an applied statistician. I want to dwell on the definition of acute, which is in the title of the symposium, as well as the definition of acute or chronic post-surgery. I heard that there were a few cases where pain continued for about a year. I also heard that there are biogenetic effects within the metabolism or genes that affect acute or chronic pain. I'm not an MD, but my question is, would a 1 year post-surgery pain be an indication that perhaps the surgery was not successful? As much as, and have there been other interventions questioning whether, for example, a hip replacement was not done properly? Maybe the alignment is not totally right. And is it justified to have another surgery to relieve the pain rather than continuing with the pain medication?
Thank you.
Thank you.
One last comment, and I'll ask Roberta Wedge to read it from the audience.
Okay. We do need to remember the lessons learned from our, quote, war on pain, end quote, where we adopted pain as a vital sign and equated liberal use of opioids with good medical practice. We should have put in place surveillance mechanisms to catch unintended consequences early on. Now we are reducing the use of opioids based on the belief that we will bend the curve in dependence, diversion, and overdose. but we need to have sufficient monitoring in place to make sure that we are not negatively impacting the recovery and rehabilitation of our surgical patients.
Okay, so thank you very much. We've now reached the time for lunch. Those of you in the audience may go up to the National Academies cafeteria on the 3rd floor and purchase lunch there. We're going to reconvene at 12:30 sharp with very interesting panel 3, and look forward to seeing you all then. Thank you.